It's good to see you back here again. Some of this will be a review for many of you, but some of it is probably going to be new to the others. My name is Bill Reynolds. I'm a plastic and reconstructive surgeon. Carpal tunnel syndrome, causation, and surgical procedure. This is going to be a general discussion of what carpal tunnel syndrome is, what it is from a medical and surgical point of view, and how is it treated, and how is it diagnosed. There's a short video at the end. It shows us releasing a carpal tunnel in someone who has severe carpal tunnel. It's not a professionally done video, but it will give you the idea of what we do, how we do it, and it will be tied to some of the stuff that we're given to you during this lecture here. Now, carpal tunnel syndrome is an entrapment neuropathy. There are many types of neuropathies in nerve pathology. There's an infectious neuropathy where you could have bacterial infections, viral infections, or fungal infections. There are acquired neuropathies like loss of myelin around the sheaths or trauma injuries. There are congenital neuropathies such as spina bifida. But what we're going to talk about today is the entrapment neuropathies. Now, what you got to remember about an entrapment neuropathy is there creates pressure on the nerve, and compression leads to pathological changes in the nerve due to inflammation's effect upon the nerve within a confined space. Now, the carpal tunnel is a confined space, and it is by far the most common nerve compression syndrome in the upper extremity. Now, nerves can be compressed in any number of ways. Nerve roots can be compressed from herniated discs. Now, what that means is if you have a brain here, and outside the brain comes the spinal cord, and the spinal cord is giving off branches to the right and left from the head down to the tail. That spinal cord is supported by backbones. There's a backbone here, backbone here, backbone here, all the way down from head to tail. Between those bones, those vertebral bodies, are discs. And the contents within those discs can bulge to the right or bulge to the left. So as that spinal cord is passing off nerves going right and left, if that bulging occurs and puts pressure on the nerve, you will have a problem with that nerve. The nerve can be a sensory nerve, or the nerve can be a motor nerve. If it's a sensory nerve, they're going to have altered sensation. If it's pressing on a nerve that has a motor component, it's going to produce weakness or uncoordinated movement. Okay. Now, there are many types of nerves that can be compressed. The perineal nerve in the lower leg can be compressed if you have an ill-fitting cast or splint. We've seen that. A lot of us have seen the ulnar nerve be compressed. The ulnar nerve is called the silly bone. All of us have hit it at one time or another. And that compression on the nerve causes all sorts of problems. So just remember that compression on the nerve is not going to help that nerve along at all. Now, carpal tunnel syndrome is not the only named compression syndrome in the body. The carpal tunnel involves the median nerve. There are three nerves that go to the forearm of the body. It's the median nerve, the ulnar nerve, and the radial nerve. The median nerve traverses the carpal canal, but more proximally in the forearm, you can have compression on that median nerve, and that will be called the pronator syndrome. Also, the median nerve can be compressed in what gives us what is called the anterior interosseous syndrome. The radial nerve on the posterior surface of the forearm can be compressed, and that's what we would call the posterior interosseous syndrome. Now, where the tibial nerve leaves the lower leg into the foot, it can be compressed there, and that's tarsal tunnel syndrome. It's kind of the counterpart in the lower extremity to a carpal tunnel syndrome. Now, pressure on sensory nerves causes altered sensation. That's why in carpal tunnel syndrome, you have people come in and tell you that they're feeling tingling or numbness or burning sensations. Pressure on the motor nerve can cause weakness. If it's completely compressed for a long period of time, the muscles will actually become atrophied. They'll become very small. That's why in carpal tunnel syndrome, sometimes you will see this portion of the palm of the hand, the Thenar eminence, some of those muscles in there are very flat. It's usually an indication that the carpal tunnel syndrome has been present for a long time, and it is probably severe carpal tunnel. Now, the median nerve is primarily a sensory component. It has primarily sensory components. That is, it provides sensations on the palm of the hand to the thumb, index, long, and the radial side of the ring finger, okay? But there's also a motor component which actually goes to the muscles of the eminence, the Thenar eminence. And we'll go over that here in just a little bit. Concept you need to understand when you're dealing with surgery and medicine and anything else, and that is that the overall shape of the body is determined by the bony structures and the cartilaginous structures below the skin. Now think about it. Your tip of your nose and your ears are cartilage. And you know they're cartilage because they move. Bones don't generally move, right? So the cartilage of the ear is simply covered with skin. Think of your forehead. The shape of your forehead is determined primarily by the frontal bone of the skull. And the muscles, the frontalis muscle and the skin are simply draped over it. And that applies to the upper arm, the shoulders, the chest wall, the pelvic bone. Now think about this. If you hold your hand out like this with the palm up, there's a concavity on the hand and in the wrist. On this side there's a convexity, but this side there's a concavity. The concavity is deepest in the hand portion of that. The wrist portion is a much shallower concavity, okay? Now, this is a diagram from Ortho McGill. It's an illustration they give to a lot of doctors. This is actually a picture with the hand down. And you can see there is a concavity here. This is caused by the bones. These wrist bones are carpal bones. There's the hamate, capitate, trapezioid, trapezium. And if you look here, the tip of the trapezium and the hook of the hamate are connected by a white structure here. That's the flexor retinaculum or the transverse carpal ligament. They're both used interchangeably in surgery and in anatomy. And when you have a bottom, two sides, and a top, that creates a tunnel. And since they go through the carpal bones, that's your carpal tunnel. And the structures inside here are very specifically arranged. The deeper structures are here labeled as 19, and the superficial ones are labeled 20. Those are the tendons that go to the fingers that allow you to flex the PIP and the DIP joints. And they're very specifically arranged inside there. Number 18 is actually the tendon that goes into the carpal canal, sort of turns at right angles and goes up to the thumb. And since these all originate in the forearm, they are the extrinsic muscles that control the hand. There are intrinsic muscles of the hand that are between the carpal bones that are not demonstrated here. But notice here, number 21, what I like about this diagram, it shows it's right up against that transverse carpal ligament. That is the median nerve, okay? And this diagram here may suggest it's quite large. I'm telling you, this canal is about this big. And you got a lot of structures going through there. There's not a lot of wiggle room in there. So swelling, for whatever reason, can cause the median nerve to push up against that transverse carpal ligament. And that's where the pressure comes from, in carpal tunnel. People can be swollen for any number of reasons, which we'll go into in a little bit. Now, this diagram is actually from Green's operative hand textbook. I believe it was the 3rd edition, but I like this. It illustrates a lot of things that we do in surgery. Just to get you oriented here, this would be the thumb side. This would be the little finger side. These are the thenar muscles. These are the hypothenar muscles. Here is the transverse carpal ligament. And notice that the previous diagram shows a cross-section right about here. This is showing us the whole surface anatomy. You can see the median nerve is coming through here. It's a dotted line right underneath the flexor retinaculum, and this is the ulnar nerve, which is also traversing through what is called by anatomists the ulnar tunnel. This structure is actually one structure, but anatomists are classifying it in a number of ways. Why I say this is an interesting diagram. Patients will come into our clinic and they will say that they have numbness in all the fingers of their hand. And if you know that the ulnar nerve provides sensation to the little finger and the radial or the ulnar side of the ring finger, how can that be if it's going there and the median nerve is here in the carpal canal? Well, it's interesting. There was a paper out a few years ago that suggested that since this is actually the same structure, by relieving this transverse carpal ligament, you relieve any pressure on this. So it's not at all uncommon when patients come in with carpal tunnel and saying that their entire hand is numb, that you release the carpal tunnel and the sensation returns to the little finger and the ring finger. There's an anatomical reason for that. If the pathology is truly in the wrist by itself. There's also an interesting thing here. It's called the palmar cutaneous branch of the median nerve. This comes up and it just provides sensation to the palm of the hand in the Thenar region. Now this is an important nerve. If you bag that nerve, if you cut it or you injure it, the patients go numb in this area. It's a real nuisance for the patient. And I'm going to tell you, for a guy who repairs a lot of nerves like I do, trying to repair this nerve is tough. Even if you repair it, they don't always get their sensation back. So when surgeons actually make this incision to get access to the carpal canal, we make the incision, you'll see this in the video, down this way, and we curve it out to the side. And the whole purpose of that is to avoid that nerve. And you'll see that in the video. Now, surgeons do it any number of ways. Some surgeons will make the incision directly in the palmar or in the Thenar crease. The Thenar crease is, when you bring your hands together, you see a crease right there. Well, some will make the incision right there. Others will make the incision just to the ulnar side of that crease by about 2 or 3 millimeters to avoid the palmar cutaneous branch of the median nerve. Now, the last thing I want to point out to you here is this median nerve as it comes out. The other important motor branch is this motor branch of the median nerve. Another name you may have seen with it is recurrent branch of the median nerve. What happens is it comes out from the carpal canal and turns back on itself and provides sensation to some of the muscles in the Thenar eminence. These fibers here are sensory fibers, and they go to the thumb, index, long, and the radial side of the ring finger. Let's see. The other things I'll just show you here briefly. You want to always avoid the radial artery and the ulnar artery. Those are not ones you want to get involved with. But those are, you don't want to cut those. Now, the muscles of the Thenar eminence. Again, the Thenar eminence is the one that helps bring the thumb inward here. You have basically 4 muscles. Abductor pollicis brevis, simply abbreviated APB. It is innervated by the median nerve. Abductor, abduction. Think of something being taken away. An abduction of a child is something being taken away. The abductor muscles help pull it away. The adductor pollicis brings the thumb back in. The adductor pollicis muscle also does more things than just adduct the finger. It helps with circular motion. It helps to oppose the fingers. There's also the flexor pollicis brevis. I've seen anatomical studies say it's only median nerve. I've seen them say that it's only ulnar nerve. I've seen them say that they're both ulnar and median nerve innervated. I don't think the final word is out. I think it's one of those ones that's probably innervated by both. Finally, the Ponens pollicis, which is a median nerve innervated muscle. Now, why is this important? If there's pressure on that median nerve anywhere in this area, then all the fibers distal, this is where the fingers would be, this would be the forearm area. If there's pressure on this nerve anywhere here, all the fibers going to this are going to be interfered with. And the motor branch of that median nerve is not going to be able to function and coordinate your movement. What do some patients say to us? They say they drop things. They drop them because they can't feel things, because the sensory branches are not able to do that. They feel numbness or tingling, and they can't grab anything. How many times have you heard your patients say that they have a decrease in grip strength? Think about it for a second. When you bring your hand together, those muscles are pulling against this anchor here. These muscles pull against that. These muscles pull against that. And when you do this, you get your grip strength. Well, what happens if these muscles are not all functioning in a coordinated way? There's a decreasing grip strength. And the explanation for that is the median nerve innervates 3 of the 4 muscles in the Thenar region. Now, so far we've talked about nerves in a very big sense, but when you really get down to it, the nerve that you're seeing is actually a grouping of individual nerves. Individual nerves are called neurons, okay? The individual nerve cell. The nerve has a cell body, it has dendrites and has axons, and collectively they are called the neuron. The axon is the part it's very long. The cell body may be up in the spinal cord, but the axon may be down all the way to the fingers. It's a very long part of a nerve, but these are grouped in such a way that forms the nerve, and we'll go over that here in a second. Now, the axon functions to transmit information to the other neurons, muscles, and glands. It tells all sorts of information. It can be sensory going to the brain, or it could be motor going from the brain to the fingers or muscles to control whatever it is you're doing. Finally, we just remember that information transmitted along the axon is transmitted what is called action potentials. These are simply electrochemical impulses. What that quite simply is, you have a nerve cell membrane, sodium, potassium, they change positions inside and outside the nerves very quickly. It's measured in millivolts and milliamps. And thank God we have nerve conduction studies and people who can do nerve conduction studies that help us interpret what all that means. Now, the nerve is analogous to a telephone cable. Having been a lineman for the phone company before I went into graduate school in medicine and dentistry, I can tell you if you look at a telephone cable in cross-section, you'll find that the individual fibers for the cable are grouped into a group that's grouped into a bigger group, and those bigger groups are grouped in what the layman will see as the telephone cable. Well, the peripheral nerve is similar to that. The individual nerves, the individual axons are covered with myelin, which are grouped together, and that group is surrounded by a substance called the endoneurium. Those groups are grouped into bigger bundles. Those bundles are surrounded by a thing called the perineurium, and then these groups of bundles are grouped bigger bundles, and that's the nerve that you see. That's covered by the endoneurium, or the endoneurium. Now, this is an illustration from the School of Engineering out at the University of California, Irvine. It's actually a very good diagram. It was Michael Klumpfer, I think. He's got the outline notes are in your handouts, and there's the links there. He's got other diagrams in there. It's actually very good. But here again, you can see the nerve itself is divided into smaller nerves, which are grouped, and inside these are smaller nerves that are grouped in even smaller. And with it are blood vessels that move with the nerve. They get progressively smaller and smaller until you get to the capillary level where all the oxygen and nutrients are exchanged, right? The blood barrier. This was another diagram I found on the internet. It's from McGill University. This is actually a nerve of a squid, and the squid's nerve shows these structures a little more clearly. You have the actual nerve itself, and it's surrounded by the endoneurium, and then you have the fascicles, the perineurium, and inside that there are groups of more bundles. And inside those small bundles are the axons, surrounded by myelin, okay? This is again a blow-up of that one. Here you have the epidurum. The epidurum is surrounding the whole thing. You have the perineurium surrounding this group of follicles. Here you have the individual axons surrounded by myelin and grouped according to how they develop in squids. Okay, now, the nerves receive their blood supply through the oxygen, the vessels that travel the epineurium, the perineurium, and the endoneurium, getting progressively smaller and smaller and smaller. So what happens is the pressure from carpal tunnel syndrome, for whatever reason, causes changes in what's happening on the connective tissue that surrounds the individual axons, groups of axons, and the nerve itself. Now, the best way to think about it is in terms of the force and the duration that the force is applied. You can have something that is occurring that's a way of trauma. Think about patients who have closed head injuries from being thrown from a convertible without their seatbelt on. They hit the telephone pole, they hit the bridge embankment. So you have a fixed bony structure, and inside that is the brain, and there's a gap between the muscle or the bone and the brain. If he starts bleeding subdurally, the blood will push the brain to the side. You see a midline shift. And when there's pressure enough to move the brain over, the nerves are not going to function right. Think about people who have crush injuries. This is probably what you see more of in work comp things. If they crush their hand from a roller in a steel mill factory, there's going to be swelling inside the carpal canal, swelling inside the the different compartments of the forearm or the hand or the fingers. And that pressure is going to start initiating some changes that's going to affect the function of that nerve. And if the function of the nerve is sensory, you're going to see alterations in sensory perception. If it's a motor nerve, it's going to see alterations in the ability to move things. The most common thing what we'll see in the chronic sense is what you see, the nerve entrapment syndromes. Now, let me back up here a little bit. When you have injury that's chronic, you're going to see initial damage at the blood-nerve barrier. There'll be swelling in there. That will lead to thickening of the endoneurium. The endoneurium, if it continues to have pressure, we'll see perineurium that becomes very thick. Okay? If that pressure is not released, again with time, you're going to see the axons themselves start to demyelinate. The myelin is the structures that surrounds the axon. It improves conductivity. Without myelin, the speed with which the nerve is conducted just doesn't happen. So you see demyelinization, and with continued pressure, the whole axon is demyelinated. It's very hard for this to come back. It's interesting that some of the newer studies that are coming out are actually correlating the different changes histologically with the symptoms that the patient has. For example, if you are having swelling at the blood-nerve barrier, people have alternating sensations of hot and cold. And then some days it's just perfectly normal. But with continued pressure, with thickening the perineurium, they start having complete numbness. And with demyelinization, they're just not feeling anything or not able to do anything with their hands. Okay. Now, what we've talked about here so far are changes to the nerve that are outside the individual nerve itself. But research is going on now which clearly shows us that there's also changes within each of the neurons, and specifically the axons. Within the axon itself, intracellularly now, there are what are called microtubules. Now these microtubules are transporting substances that are used by the neuron. The microtubules can transmit substances antegrade or retrograde. And this becomes important because if you're putting pressure, that transmission does not occur very easily. So if you impinge the nerve at the axon level, this back and forth flow of the microtubules is impaired. It impairs the functioning of the nerve. Now, this leads to this idea that's called the double crush. It was noted in patients who had cervical injuries that they were more prone to develop carpal tunnel syndrome or pronator syndrome somewhere else. And the reason for that, they speculate, is that the compression on the microtubules in an area, let's say the cervical region, makes them more susceptible to damage distal to where the initial compression is. Okay? Now, that led to another idea called the reverse double crush. Remember, the microtubules go anterior and retrograde. So if you're compressing, let's say in the carpal tunnel, are they more susceptible to getting problems in the proximal forearm, the arm, the shoulder, the neck? And this always fascinated me. I still haven't heard a really good explanation for it, but I'll kind of tell you what I think this is. How many of us have had patients who've come in and they will say they have carpal tunnel syndrome, but they also have forearm pain, elbow pain, arm pain, shoulder pain, neck pain. And then when you go in and you release the carpal canal or the carpal tunnel, these symptoms in the forearm, elbow, shoulder, neck disappear. I think it has something to do with the retrograde aspects of compression on the median nerve in that canal. Now, if a patient, now this occurs in my practice about 20% of the time. It's not every case, but it's a significant number. That's why if in our practice, if they have carpal tunnel syndrome and forearm pain, and we can't find another reason for the forearm pain, we still release the carpal tunnel, and many times it will, the problems in the forearm, the elbow, and the shoulder will disappear. But if a patient has, let's say they have golfer's elbow or tennis elbow and they have carpal tunnel, guess what? You know, when you release the carpal tunnel, they still got golfer's elbow and tennis elbow. It's a completely different problem. And trying to explain that to our patients is sometimes difficult. That's why you guys are valuable, the nurse case managers and people that deal with them and the OTs and the PTs, because you can pave our way with words, or we pave your way with words. Because if they have golfer's elbow or tennis elbow and you release the carpal tunnel, guess they're still going to have it and they're still going to need other treatment. Okay, compression or pressure on the nerve causes changes within the nerve that alters the function. So we have a breakdown, an alteration of the nerve-blood barrier. So we have decreased oxygen delivery, rendering the nerve more susceptible to other injuries because of the microtubule issues. There's endoneurial swelling, thickening of the perineural tissue, demyelinization if pressure is not relieved, and degeneration of the axon in cases of something that's very severe. With that as background, I want to kind of talk about what patients come at our office with carpal tunnel or syndrome. And I'm going to tell you that the greatest ally any physician has, I don't care if he's a cardiologist, family doc, urologist, general surgeon, orthopedic surgeon, rheumatologist, the greatest ally we have as physicians and clinicians, because we have a lot of nurse clinicians and we have a lot of physicians assistants, our biggest ally is the history and physical. And I think I'm talking to most people who know what that is, but in case you're not, I'm just going to go over this very quickly. A history and physical contains these parts. There's always a chief complaint. What brings a patient to you? Okay. How did the patient get to the point where he had to go see it? That's the history of Presnellis. What problems have they had in the past? What surgical problems have they had? What medicines and allergies are they on? The social history and family history. Never underestimate what the social history has to do with what the problems you're dealing with. Okay? I'll go over that here in a little bit. And then the review of systems. It's a quick yes or no answer to some questions that patients will sometimes forget they had wisdom teeth extracted or they had their appendix out. You can usually pick that stuff up in the review of systems. Then, of course, the physical examination, which is directed to the patient's main concern. For carpal tunnel, we're looking at the upper extremities. So let's just kind of go through this. Now, for a patient who has carpal tunnel syndrome, they will usually have a number of complaints. They have tingling or numbness, they're decreasing grip strength, for the reasons you know earlier from what we talked about on the anatomy, sensory and motor components of the median nerve. They will report decreasing grip strength, sometimes dropping items at home and at work. Now, these changes are not always uniform. And the reason for that, again, goes back to the anatomy. The superficial fibers on the median nerve are usually going to the index and the long finger. So if someone comes in and tells you it's my long finger, my index finger, they're not talking about things like I'm dropping things yet. You know that's probably very early, and it's probably pressure only on those fascicles or with the fibers that are going to the index, because those are superficially located. Okay? Well, the physician is kind of figuring this out from the get-go. He knows because he knows the anatomy, knows the physiology, he's heard this stuff before, and he's been trained to do it. The history of Presnellis is what happened that got the patient to the stage he's at. It's some of the most interesting stories if you will just sit and listen. You know what I'm talking about, right? I'm a burn surgeon, guys. I'm going to tell you the most fascinating stories I ever had was as a burn fellow and as a burn director. How did you get burned? And it's all over the board, and you're absolutely amazed at just how people injure themselves in burns or anything else for that matter. In Detroit, where I did my general surgery training, we used to call it some dude syndrome. Some dude shot me, some dude stabbed me, some dude ran me over, some dude, but here we have, just sit and listen to the patients. They will tell you what happened and how it went, okay? In the carpal tunnel, they will say, you know, I've always had some tingling numbness. I have to wake myself up at night and shake my hand. And then I go right back to sleep. But lately, it's getting worse than that over the last 4, 5, 6 months. Again, emphasizing the chronic nature of carpal tunnel syndrome. It doesn't happen like that unless it's traumatic injury where they crush their hands or they have some electrical injury. But sit and listen to them, and they will tell you, a good clinician, and all the doctors in here will tell you this, if a good clinician is one who will pretty much figure out what is wrong with the patient based on the history and physical examination. And he uses things like x-rays, CT scans, MRIs, nerve conduction studies, laboratories, to figure out or to confirm what he already suspects. Okay? Common things occur commonly. And if it doesn't present the way it should, then you can use these other techniques to nail down what's really going on for the patient. Remember, history and physical exam is your greatest ally. Now, certain medical conditions are associated with carpal tunnel syndrome: pregnancy, thyroid disease, diabetes, growth of tumors in that area. This is why we ask these people these detailed information. The nurses a lot of times do that for us. Some of us like to do it ourselves just because that's what I've always done, that's what I do. People will ask me, well, how is it that pregnancy causes carpal tunnel in some patients? Well, we have a lot of women here. When you guys became pregnant, did any of you get big? Get swollen? Yeah, well, well, swelling occurs externally, but it also occurs internally. And remember, that canal is only this big, and there's a lot of structures inside there, and if they keep swelling up, it's going to push the transverse carpal ligament coming over here, swelling pushes the carpal tunnel, or the median nerve, up against the transverse carpal ligament. Guess what? Pressure on the nerve, they're going to get symptoms. Well, the treatment of a woman who's pregnant with carpal tunnel syndrome is don't do surgery. When the baby's delivered, the swelling goes away. The symptoms go away. How about diabetes? That's always a bad one. Diabetic changes. I mean, maybe their changes are not really related to carpal tunnel, but maybe due to the effects of diabetes. Growth of tumors. In all the years I've done these, all the thousands of these carpal tunnels we've released over the years, I've never seen one with any tumors inside yet. It's just maybe it's just the way my practice is. Back on past medical history, some people have Parsonage-Turner syndrome. You probably picked that up there. Brachial plexus neuritis. That could mask itself as carpal tunnel. And knowing what that past medical history is will give you a clue about what's really going on, what may not actually be carpal tunnel syndrome. Okay, surgical history. Have they had neck surgeries in the past? Okay. If they had neck surgery, well, what was it? Was there something up there that may have actually caused the problem? Were there other surgeries on the neck? How about recurrent carpal tunnel? Has the carpal tunnel been released in the past? It's pretty rare, but they do come back again, guys. Let's move through this here. Medicine and allergies. Before you operate anyone, you better know if they're on Coumadin or anything else that may prevent you. If you're covering them with antibiotics, you want to know if they're allergic to it. Again, you pick this up on the history and physical. What's surprising to me was the tobacco was not associated with increased incidence of carpal tunnel. It's probably the only thing that tobacco has not been associated with. It's a little unusual, but I don't think the final word is out on that. But social history is a big one. If a patient, this actually happened to one of our patients in, how much time do I have? 5 minutes. Okay, we may not get to this video, but we had a patient whose father had carpal tunnel syndrome. He'd worked at a local manufacturing plant. He used his hands to grind metal, and he truly had carpal tunnel after doing it for 30 years. His son graduated high school, starts working at another manufacturer, and within 6 months he had carpal tunnel syndrome. I didn't believe it. He saw his father got a new bass boat from the settlement because it was workers' comp, and I think he wanted one too. And so in that particular case, a nerve conduction study clearly showed he doesn't have it. It's all normal. And he's a pretty savvy kid. He's on the internet. He knew what we were looking for, tingling, numbness, things like that. And quite honestly, he didn't have it, so we made him wear a splint. He got tired of wearing a splint for a year and a half, and this thing's got better on its own. And he was very thankful to us for that he didn't have to have surgery. This came from Susan McKenna's book. She authored the chapter on compressive neuropathies in Green's latest textbook, the co-author with Christy Novak. Susan McKinnon is the chairman of plastic surgery up at Washington University. She's a sweetheart, just a great gal, did a lot of great work. But they had something there which applies to what we're doing here in work comp. She says, except for significant exposure to vibration and specific occupations with high prevalence carpal tunnel, it is generally accepted that work is just one component of many factors that contribute to and aggravate compressive neuropathies. I think she's sensing that in the 1990s, everyone was trying to get this on workers' comp because there was a settlement with it, the social side of this. But when you really get down to the studying what causes carpal tunnel, it may not always be work-related. It may be medical component parts to it. There may be previous surgical things. They may have a past medical history of having had previous surgeries in that area. So the final word on causation is not in. There's the medical side, and then there's the legal side, which you guys are primarily dealing with. And you got my sympathies, because that's hard to do sometimes, okay? We'll show you what we're doing here. We'll stop it along the way just to show you why we do things a certain way. Okay, We're making the incision, and we're just going through the dermis, and we turn the scalpel blade toward the ulnar side. The reason it's bloodless is we're doing it under a beer block. Very little bleeding associated with this under a beer block. I use the Bovie cautery to take care of the little tiny bleeders that are occurring. Then my nurse, Mary, she takes this two-pronged skin hooks and she pulls the skin edges apart. Now the carpal tunnel is actually about this far below the skin surface there, so we don't really have to go down very far. It's also why we don't have to, these procedures don't take very long to do. I'm getting rid of some more bleeders here. That's with the Bovie cautery. That's our best friend there in surgery. I really like the Bovie. But if we get to a point where there's no more bleeding, and I'll switch over to iris scissors, curved iris scissors, and this little instrument here is a elevator. And what I do is I spread the tissues there. You'll see the motion like this. And the reason for that is to prevent injury to that sensory branch of the median nerve that goes to the Thenar eminence. And you're always looking for it because, like I say, you do not want to divide that rascal. Again, spreading the tissues, and if the nerve is in there, you're pushing it out of the way. And then you get direct vision of this little white thing here is the carpal tunnel. And there, the blood, I'm using the Bovie again to stop the bleeding right there. That's going to occur when the beer block is done. Again, spreading action. You can see the transverse carpal ligament fibers are running radially, ulnarly. And you divide a few of them, and you don't go down very far because you know that nerve is just right under that thing. You don't want to cut the nerve or injure it. Again, dividing some of these fibers, and we just want to get down to a point where we insert this freer underneath the flexor retinaculum so it acts like a barrier between the nerve and the flexor retinaculum, which you're going to divide. Okay, the freer is inserted below there, and this is a 15 scalpel blade, and with the freer between the nerve and the flexor retinaculum, you simply divide it. And then you reverse the direction and go proximally and divide the flexor retinaculum that way, always protecting the nerve with the freer or the elevator. You can see the fat tissue there, and Mary's doing a great job holding this out. You can use rag nails to pull the fat out as well, but in this one we just are able to do it. Okay, stop. Oh, I meant, well, that white thing is the nerve, and what you see in there is this nerve. Here you got you have the flexor retinaculum, you divide it, and the contents underneath it start welling up. The only reason it wells up is there was pressure putting it down. When you see the welling up, that's a good deal. That you know that you're going to have a great result. Now, let me just digress here and just tell you one thing about workers' comp that you guys have seen before. What happens when you get a patient who gives you the great history and the physical examination, and you know by just that they have carpal tunnel syndrome? And you get a nerve conduction study that shows, hey, they've got moderate or severe carpal tunnel syndrome. You do the surgery and you see the tissues well up. You know everything is going to do just fine. But what happens though when you get a patient that has a great history and physical, you do the nerve conduction study and it shows they have normal nerve conduction studies. There's a divergence between the history and physical and the nerve conduction study. You know, and that's where you go back and you're listening to the social side of it. Is there something else going on? Is it work comp or is it not work comp? I'll tell you, the easiest ones to do for me are the non-work comp carpal tunnels. There's no interest in what happens at the end of workers' comp because they do get a settlement, right? And I mean, if they're truly injured on the job, they should be reimbursed. But are they doing it when there's a divergence there? What happens? If we still err on the side of the patient, and I do a carpal tunnel release, and that nerve just sits down there, and all the structures there, I think to myself, God, what did I miss here? he probably didn't have it, and they're great actors, some of them. Those of you who have dealt with clinical situations know that there's some patients, they fool us. We're not perfect as physicians or surgeons, not by any stretch of the imagination. But anyway, it's wonderful having you here today. Work Complete is a great organization. The Cox people have been very good, and I hope you guys will use it. Do any of you guys have any questions? I know I ran over here. Yes, ma'am.
Can you have a carpal tunnel with a negative nerve conduction study?
Negative meaning a normal nerve conduction?
Yes.
Yes, I've seen that a few times. That's why those are the hardest patients for me to deal with. And I usually will err on the side of the patient, because if they're a 50-year-old guy, been on same job for 20 years, putting nut and bolts on the car, I usually favor them. If it's someone right out of high school that hasn't been in the workforce long enough to develop something that's chronic, I probably err on the side not on the patient. But if I finally make the decision to go to surgery, when I release that ligament with that 15 blade that's inverted, and I Did you have a question?
I was just going to say, don't you usually want to pick somebody that has done a lot of EMGs, that has been proven to be very good at it? Because if you just let them go to somebody in their area that they want to go to for the EMG, that doesn't necessarily mean they're good at administering it, or if the results are going to be.
Right, especially in the wintertime. They don't warm up the hand before they do, or the arm before they do it.
Into that where I just had to say, sorry, you're going to have to,
It's like anything you do. The more you do something, the better you're at doing it. Somebody who does 5 or 6 or 10 nerve conduction studies a week, has done it for 15 or 20 years, they've done pretty good. They don't want to make mistakes any more than anybody else does. Someone right out of residency that maybe spent 2 months on it as a rotation in neurology, yes, they have to get their experience. But you will look at that a little bit different. Just like they did me when I was just right out of residency, Hey, how many of these have you done? Facelifts and tummy tucks and carpal tunnels and tendon repairs. And you can't lie to them, but you have to be honest with them. But you gain that experience. That's why I think some of our best clinicians are the people who have been out for 10, 15, 20, 30 years. They are outstanding people when they come out of residency. They truly are. And they're at some of the best institutions, but they don't have that intuition that something else is going on. Yeah.
Have you noticed in your surgical experience a lot more like the men with the great big fat meaty hands that have more carpal tunnel than the long slender fingers?
The long slender fingers, I don't see much of them. Obesity is one of the risk factors for that. So if you see someone who's like 400 pounds or a bodybuilder, I think there's something there, but I don't know the exact mechanism. Again, it boils down to the surgeon at the end when he's releasing it, if he gets that far. If I see those contents well up from the carpal canal, then I'm thinking, well, there was pressure on that nerve, which set into motion all those things we talked about. Blood-brain nerve barrier problems, endoneurial swelling, perineural thickening, axonal loss, if it's untreated. Okay?
Do you have see an instance between carpal tunnel release and then future trigger finger problems?
I know that we have that, but I don't know if they're related casually or if they're separate problems. Both are related to inflammation, so it could be, but I don't know that there's a final answer on that one yet. I do see people with carpal tunnel and trigger fingers, and it's interesting, they're usually in the index, long, and ring fingers. So I think yes, but to say definitively in a court of law that's guaranteed 51% certainty that it's due, I don't want to go down that trail because I don't know. But we do see it. And while you're doing the beer block, it doesn't take long to get in there and clip that A2 pulley, or A1 pulley rather, to release the trigger finger. Okay? Okay, thank you all very, very much.